So thank you very much for joining us tonight for another webinar from the East Sussex Eye Group. There's somebody who's asking a question. Do I need camera on? No, you don't need a camera on. So I don't think I've allowed you to put your camera on anyway. So this webinar will take about an hour and there'll be time at the end for questions as well. There is one CPD point available for optometrists and dispensing opticians, and I will get the certificates out to you within the next 10 working days is what I get given the timescale from the GOC. I won't be able to do this weekend, but I'll get them out to you as soon as I can. It says the webinar is being recorded. I'm not sure if we're going to be able to put it on our YouTube channel yet, but I will let you know on that. There is a Q&A box at the bottom of your screen, so if you have any questions throughout the webinar, if you type your questions in there, and at the end of the webinar, I'll then present them to our guest speaker. There is also the chat box is open, so you can ask any queries about any slides as we go along, and Sarah said she'd be more than happy to answer those. So I'd like to introduce tonight's speaker, Sarah Leppard. She is an optometrist, an advanced clinical optometrist working for East Sussex Healthcare Trust. She has gained a professional certificate in glaucoma from Moorfields, what's yours? City. And she performs anterior laser eye procedures, and she's a non-medical injector working in the macular clinics. She also performs refractions on children and adults with special needs. And tonight she will talk to us about the art of eye examinations of adult patients with additional needs, adapting with ingenuity. So, Sarah, I would like to pass on to you. Thank you very much.
Right, just share my screen. And then we'll get started. Okay, so thank you very much for coming to listen to me talk for a little bit. And hopefully you all know why you're here and what you're wanting to listen to. So, quick declaration from me. I've got no disclosures, no conflicts of interest, and I'm not being paid for this. I do work for East Sussex Healthcare Trust, but this presentation is independent to them and it's from me. So who am I and why am I speaking to you?
I can't see your, are you sharing your screen? I can't see any slides.
I am. Okay, we'll go back. Hang on a second. This worked before, didn't it? Oh, it's because I haven't pressed the share button.
There we go, we can see it.
Okay, let's go. So, yeah, done all of that. So who am I? Ian's already done a little introduction for me, but I am Sarah, and I qualified in 2010 from City University. I've got qualifications in dispensing and optometry, and I've worked in private practice and multiples. I am very lucky that I've spent more than half of my career in either the hospital eye service or with the outside clinic, and in both of those settings, I was really sort of given high exposure to patients with additional needs and disabilities, and kind of got a bit of a love for it, and it's very, very rewarding. So I don't profess to be an expert, but hopefully my experiences will help you guys. So I married my childhood sweetheart. We met at 15 and married him, and I'm a guide leader as well, and within guiding I've helped a lot of children and adults with additional needs too. And in 2012 my husband actually had a car accident, so I'm also his carer and have unfortunately witnessed disability discrimination over that time. I have a son called Ethan who also has autism, and I've also got another son called James who's just a nutter because the jury's out on that one at the moment. So quick session outline. We're going to do some definitions. We're going to explore the legal requirements. We will look at reasonable adjustments, and we'll look at the role of the hospital eye service. I've got a few, well, let's call them case scenarios because they're not real case studies, but they're sort of worked examples that we can work through, and some other information, and hopefully some question and answers at the end. So if we can do, we've got a few polls to make this interactive. So Ian, would you mind doing poll 1 for us? Okay, so if you can answer on the screen. And we'll give it a few moments to see where you sit with that. So the question is, where do you stand with the statement, I can manage patients with any form of additional needs presenting for an eye examination? So give it a couple more seconds. I think we'll close that now and have a look at the results. Because if you're all extremely confident, we're going home now. Right, great. So that's what I thought. We'd sort of all be in the middle. So hopefully today we'll consolidate sort of some information, maybe give you a few other ideas and resources that you can use. So first we're going to start with the definitions. So additional needs is when a person requires extra support for everyday living. And this could be due to a health condition, a learning disability, a sensory impairment, or a developmental condition. And it could be present for their whole life, but it could be something that has come on later in life. People with vision impairments and hearing impairments are within that. So we come across people with additional needs all the time. Now, the sort of cohort of people I'm going to be concentrating this on are the more complex additional needs. So I'll just quickly define learning disabilities. So a person with learning disabilities has significantly reduced ability to understand new or complex information, to learn new skills, and they have a reduced ability to cope independently. They will have started before adulthood, and they will have a lasting effect. So they affect them across all areas of their life for their whole life. There are different degrees of learning disabilities. So you could have a mild disability, which you maybe as a practitioner wouldn't even pick up on, to profound learning difficulties. And if we can have the second poll, Ian. There we go. So autism, dyslexia, and ADHD are examples of a learning disability, true or false? It's quite a quick and easy one, so I'll only give you a few seconds on this one. What's the answer on that one? We've got an answer here.
Is that showing the results?
No.
Oh, I think my computer's having a blip. I'm just going to try it again.
That's fine.
Share results again. Is that showing the results now?
No. Can anyone else see them?
I've got 85% said true and 15% said false. And
okay,
it's showing this results, but obviously not.
Fair enough. Well, I'm quite glad you fell into that trap. So it's actually false. Because why is my slide now not working? There we go. Learning disabilities and learning difficulties. This is the difficulty here. So a learning disability it's something that starts earlier in life, and it affects the person's intellect across all areas of their life. Okay, so a learning difficulty is where it just affects one small portion. So examples are dyslexia, dyscalculia, and dysgraphia. There's auditory processing disorder, visual processing disorder, which we probably all know a bit about, and things like autism and ADHD are actually developmental disorders. So last little bit on learning disabilities, you can have learning disabilities in alongside other disabilities, other problems. For example, everyone with Down syndrome will have a learning disability, whether that's mild or profound. And many people with cerebral palsy do, but not everyone. Interestingly, around 30% of people with epilepsy also have a learning difficulty. Okay, so we'll just move on to talk about autism quickly. I'm going to get lost on my notes. Okay, so autism's been around, sort of bumbling around for a long time. It comes under lots of different names. There are lots of different terms that are used for autism. So sometimes it's referred to ASC, which is autism spectrum condition, or ASD, autism spectrum disorder. I don't really like it when they say disorder for things because it makes it sound, yeah, I don't like it. Anyway, so autism is a lifelong developmental disability, and it's to do with how a person communicates or interacts with the world. Okay, you've probably all heard the autism spectrum, and we're all on it. Well, actually, we're not all on it. It's pretty black and white. You either have autism or you don't. You may have autism traits, but you either have autism or not. Within autism, there is a spectrum. So you can have somebody with mild autism, you can have somebody with quite significant autism, you can have high functioning autism, but basically no two people are the same. When you've met one person with autism, you've met one person with autism. It's a complicated condition, and it's something that you need to understand each person's individual needs. Okay. Sorry, I've lost my note. There it is. There's sensory processing difficulties that are often associated with it. For example, Ethan's got a superhuman sense of smell, which is both a blessing and a curse. He struggles with noises, so will often wear ear defenders. Sometimes he needs a bit more stimulation, but he has a chew toy that he has to chew on, or fidget toys to keep him busy. And lots of people will display that in different ways. Some people seek out some sensory input, so they might stim, which is where they're sort of, they might move, or jerky movements, rocking, or hitting themselves because they're wanting that sensory input. Things like heavy blankets and something called a stretchy sock, which kind of compresses them. It gives them that, it's actually a proprioceptive feedback, which I did my undergraduate dissertation on proprioceptions in extraocular muscles. So that's a boring read if anyone wants it at some point. So the other thing to bear in mind with somebody with autism is that they're quite literal thinkers. So when you're communicating with them, I would avoid sarcasm or colloquial phrases. So, for example, saying to somebody, "I'll be with you in a minute," they could then turn around and say, "Well, I've counted 60 seconds and you're not ready, so you lied about being a minute." So stick to the facts and avoid the sarcasm, and to avoid confusion. There are big communication differences along this spectrum. So you may have people who have poor eye contact or no eye contact. You might have non-verbal or non-speaking autistic people. And also people with autism, the PC way of saying is people with autism, but some people will refer to themselves as having autism or suffering from autism. Generally, from our point of view, just across any of these conditions, don't say suffering with. Generally, they're not suffering. Okay. So autism isn't a learning disability, as we said earlier. In fact, it's quite often quite the opposite. They're often very highly intelligent, high functioning. All these people have diagnosed autism. I'd quite like the bank balances of the top three. They are very smart people. So ADHD is attention deficit hyperactivity disorder. You can also have ADD, which is the same but without the hyperactivity. But these people with ADHD or ADD will have inattentiveness and possibly hyperactivity and impulsiveness. So they may have difficulties sitting still. They may have difficulty keeping attention on one thing for too long. They may make careless mistakes or appear forgetful, having poor memory issues, and constantly sort of hopping from one activity to another, quite disorganized or organized they may be. The hyperactivity and impulsiveness, the risk element, they might take risks and be very impulsive on things as well. And just like autism, no two people are the same. So just a really quick note on acquired cognitive impairment. I don't want to spend a lot of time on it because this is including things like dementia, which would if you want to seek out a good lecture on that, I'm sure I can point you in the right direction, but we're not here to discuss that too much today. But most of what we're talking about can be applied. So this area, as I say, covers things like dementia, a traumatic brain injury, a stroke, and is acquired later on. But a child may have an acquired cognitive impairment as well. So you could have a child who's had it's like meningitis or issues early in life, but not in the first few days of life. Cerebral palsy is another name given to a group of condition that is from a disruption of a normal development of the brain. That could be just before a child is born, or during birth, or in the first few days of life or first few weeks of life. There will be some form of disruption to the brain development. People with cerebral palsy, again, it's a spectrum. You have people who've got very mild cerebral palsy and you may not notice it's just a few problems. You may have somebody who has quite stiff joints and is using a wheelchair to mobilize. And it can, I think I said 30% of people with cerebral palsy will have a learning difficulty as well. Okay. So the last definition I want to talk about is cerebral cortical vision impairments. You may already know this very well, but it's a form of vision loss that is based in the brain. It's present with a fully working eye. It's a very big subject that probably needs its own lecture at some point, not from me, but with one of the ophthalmologists maybe that can talk you through that. Again, it's a spectrum. So patient can have vision as bad as no perception of light, but they can have perfectly normal vision, and it's actually to do with movement or color or something else with their vision, and it can fluctuate too. So one minute they can be okay, and next minute they can struggle. I think we need poll 3 now, if that's okay, Ian. And whilst Ian's doing that, the most common cause of visual impairment, of cortical vision impairment, is actually cerebral palsy. In fact, about half of the cases of CVI that are diagnosed are children or adults with cerebral palsy.
Is that showing?
No.
Okay. I'm going to try just relaunching it. I think it's my computer.
Don't worry, I can
come back again.
I think I know what the question was.
I'm trying to launch it.
Don't worry if not.
Sorry, it's not working.
That's not a problem. So the question I think was asking whether CVI is always a congenital condition from childhood, or whether you can it can present later on in life. It depends what source you read on that one. Whether acquired CVI is a true CVI or not it's a bit of a debated subject. And I feel from what I've read, if it's accompanied with acquired CVI, then they are the same, because essentially they are the same thing. So I just want us to, this is present in patients with dementia, or can be present with patients with brain injuries. But I want you to just consider that hospital corridor for a moment. So I said it might not be about visual acuity, but more about the perceptual trouble with seeing movement and things. So this hospital corridor, it may well appear like a river, and that's why somebody would struggle walking down it, because it's a blue floor, blue river. I'm going to get wet if I walk down that. So often you have patients with dementia that may struggle to walk down a corridor, or they sometimes skirt around a dark carpet or a mat on the floor because they think it's a hole. Those sort of things. It's the brain playing a bit of a trick. Or the brain may become hyper-focused on something, so may stop seeing the surroundings because it's focused in on the chair that's in the corner and you can't see anything else. Or so you might see just parts of the image. Or you might not be able to process movement, so the person at the end of the corridor is calling your name and suddenly they're standing in front of you. So the law when it comes to us providing eye care for patients with additional needs, there's 3 bits of legislation that really come into play here. You've got the Mental Capacity Act, the Equality Act, and the Opticians Act, which obviously governs everything we do. So there is a legal obligation for eye care services to make reasonable adjustments to ensure that people with additional needs and disabilities can access the services in the same way as other people. And that sentence there is what I really want you to, if you can only remember one thing from this lecture, that is what I want you to remember, that we have a legal obligation to ensure that they can access the services in the same way as other people. Okay, so they're talking about reasonable adjustments. Reasonable adjustments are changing our approach to provide accessibility for somebody. So you might need to make reasonable adjustments for an elderly person with a walking stick, or there's a lot of other people you might need to make reasonable adjustments for. You hear the term often in HR, so you might have to make a reasonable adjustment for a pregnant colleague, or a colleague who needs parental leave, for example. That's all reasonable adjustments so that you don't discriminate. So the reasonable adjustments we're thinking of here, they could be having a ramp, so you can get ramps that you can put down to allow access into a building. It could be to provide fidget toys for somebody to fidget with through the appointment. My dentist actually has a box of fidget toys at reception, and when we go there, it's a bit of a lucky dip. It's a free thing. They get them off of Amazon. You can get a big job lot, and it's a really nice touch when we go to the dentist to be able to have a fidget toy. And in fact, I hate the dentist, so they give me one too because it keeps me happy. So other things could be changing the appointment times. This is one we all know about. So it's longer appointment times, or offering multiple visits. Choosing altered test techniques for people, i.e. alternative charts. Thinking about the time of day that's better for that person. So it may be better to arrange first thing in the morning or last thing, so that the waiting room's a bit quieter. And think about turning music off, or changing the lighting, and trying to give continuity of care with the same staff. There's plenty of things that you can do, and I'll highlight some resources. You're going to hear Seeability a lot through this. If you haven't heard of Seeability, I recommend having a read of their website. I'm sure you all have, but they're a charity that are present to basically campaign and work towards making eye care accessible. And they have lots of downloadable resources. One of them I've highlighted on here is a picture story of having an eye test. There's another picture story on here, which is actually a book. It's called, the company's called Books Without Words. They're not children's books. They are books for adults. They also have other adult themes like checking for breast cancer and things. So they are specifically for this cohort of people. And there is one about going to the opticians that you can buy. So another reasonable adjustment is having things in large print and or braille as well. That's all a reasonable adjustment. So communication. Don't be scared or concerned about asking somebody how they best communicate. Okay, it's important to address them rather than the person that's with them, the carer or supporters. It's quite dismissive to not address them. It may be that they need help answering you, so it might be that the person next to them answers with you, but it's important that you don't disregard them and speak over them. And finding out how best to communicate with them is in advance is quite handy. So just ask. Ask to see a care plan, because that's going to give you some other information as well. I'll talk about the seeability template in a moment. Giving them plenty of time to answer and don't try and finish their sentences. So I actually had a patient having an IVT injection the other week who has issues with sort of a delayed speech. It takes a long time to answer a question. It's all in here, but it can't come out. And we just had to allow a lot of extra time. And actually, he could nod, he could give us yes, no, he could hold his fingers up to tell me how many fingers that he was seeing. He was understanding everything I was saying, but it was just giving him that time to allow him not to feel rushed or panicked. Because the more we rush him, the less he's able to get out. We talked about using sarcasm and things, but using plain English is important. So capacity and consent, just be mindful about this. Somebody who may appear to not have capacity may have full capacity. So just don't assume, okay? And you've obviously got powers of attorney that could attend. So understanding whether somebody has a power of attorney and can help make consent choices for the patient as well, but never assume. Next, I'm going to actually show you a little video, if that's okay. It's a clip from a TV series that's still on the BBC iPlayer. It was called Inside the Autistic Mind. And if you haven't seen it, I really, really urge you to all watch it. And I want you to have a real honest thoughts whilst you're going through this. I want to know what your conceptions were when you're watching Murray, the young man that's in the video. I want to know what your first thoughts are and if that changes at all. Okay, so oh yeah, never assume, because it makes an ass out of me and you. Forgot I put that bit in. Okay, so here's the video. It there. When I watched that, I sat in tears, because as I watched it, I thought he had a learning disability. I thought he didn't have the same intellect, and I never thought when Chris Packham reads that would come out. So my preconceptions were really off, and the whole series is fantastic. So make sure you watch it. And it was really just to highlight, don't assume that somebody isn't completely aware of what's going on just because outwardly it doesn't appear so. So very quickly, I'm not going to go over the Opticians Act. You know how to do an eye test and what is expected of us in doing an eye test. And you also know the college guidelines. And you must, when it says must, you've got to do that. That's a legal thing. When it says you should, normally include, the should is ideally you should do this, but it's not in law. So that's just a standard for a standard sight test. So adapting an eye test performed by flexible optometrists, that's what you're going to be, and we're adapting with ingenuity. So think about it before they've even stepped inside your room. Booking an appointment prior to booking the appointment and prior to the appointment, okay? I don't know whether it's commonplace to ask every single patient booking in for an appointment if there are any additional needs or requirements. I can remember being in practice and being really caught off guard because suddenly there was a patient that wasn't able to get upstairs, and I'd been working upstairs for the whole morning, and suddenly there was a mad dash to get downstairs, get the room open, get the computer on, get everything set up, bring down all the equipment that I needed, and there was no extra time allowed for an appointment. That's very frustrating. So by asking all patients and getting into a habit, then you don't get the surprises. Encourage reception staff to ask for care plans to be brought, or history forms to be brought in, or invite the patient into the practice prior to the appointment to see the environment and meet the team. Providing picture resources, you can make your own, but there are plenty out there to give them an idea of what's going to be expected of them. I like the idea of each practice doing their own and taking photographs of inside their consulting rooms, and you could have it laminated and just available. It's that whole failing to prepare is preparing to fail. If you've got all these things ready and in place, then it just makes things easier. So history and symptoms, this is a form that you can download from Seeability, and I would suggest that this goes out to a patient prior to your appointment. It can go out to them in the post, they can download it and fill it in and email it back, probably with the help, or maybe with the help of somebody at home. It's quite a chunky document, but it asks everything that you're going to ask. It's several pages long. It gives them the opportunity to get everything written down, their history, and it asks them to bring things to the appointment. So time is such a precious thing in any sight test, especially if you've got a patient that you kind of need to get on and keep attention spans. So prioritizing that time. So having your history and symptoms done, that's a win. So you can quickly read through it, and I think it will really, really pay off. So again, you could make your own one, but there is a free downloadable resource just sitting there ready to go. So testing vision. So I really don't like the idea of anyone who can't manage letters just being shown pictures, because I think if you're an adult and you're shown pictures, it might be a bit condescending, and there are other ways to do other ways to test vision. So the Land.Cs or tumbling E's are good. You can get a person to point which direction they're pointing, or something with a matching card. So there's the Lear symbols and the HVOT charts that only have the 4 letters randomized and repeated. Most computer charts have various different options, and you can also randomize letters. Single octatypes aren't ideal, but you can add crowding bars round, and if it's better than nothing. I've put a beware of unhelpful helpers on there, because we've probably all had it, where you're testing somebody's vision, usually with a child, but it sometimes happens with carers of patients with additional needs, where they're saying, can you see that letter? Can you? It's a round one. It's not a C. No. So that's giving the answer. So you know, just be aware of the unhelpful helpers. They come up again later. So what if they can't manage that? If we can't get anything out for for a quantitative assessment. So there's objective assessments of visual function. So you can ask yourself questions. Are they fixing and follow? Are they interested in things in the room? Do they object to occlusion of either eye? Is it equal? Do they reach for toys or things if you hold them for them? And are they holding gaze on anything? And people can help understand that. Now, again, seeability, have got a form for this. That is also going to be my catchphrase, because pretty much seeability have a form for everything. This is a fantastic tool. Again, it's a downloadable resource that they can fill in with carers, or you can help fill in too, and it just looks through everything. It kind of covers the CVI aspects as well. It looks at it asks all these questions that we've got here. There's various questions in there. It's a really good resource to flick through. And either side of that, so there is some preferential looking paddles there. Obviously, you've got Kay's pictures, not case pictures, sorry, Cardiff cards and Keeler cards. They aren't specifically for adult use. They do say for children's use. I've read somewhere that you can get Keeler cards for adults. I fail to see how it's going to be any different, for a start. And secondly, I can't find where I read that, and I can't find any evidence of that, so I haven't put that on there. But these are Lear gratings, and they are marketed and tested for use with young children and adults with learning difficulties. So that's there's an evidence base behind those specific ones. Okay, so determining refraction and considering a cycloplegic refraction. So if no glasses are currently worn and you've got no prior records and you're struggling to get an assessment of vision, it's probably worth considering doing a cyclorefraction, even on an adult. Just be mindful that you might need to check accommodation prior to that. You could do predilation at home, might be a bit easier for you. And we probably need to think about this dynamically, especially if you're bringing somebody back for multiple appointments. It may well be that you do anything that requires a dilation, you bundle together, and all the other tests you can do at the next visit, or you you can do everything in any order. You don't have to do it in a specific order, and there are probably things that can be clumped together, and there are some that can be a bit more challenging with overstimulation of a patient, for example. And dynamic retinoscopy is always in the bag as well. So sensory overload incoming. So we're about to move on to talking about checking eye health. And I think if you were doing a sight test in a normal order that we would all normally go through, then this probably is the bit that's a little bit more stimulating to somebody. So just imagine, if you will, you have attended for an eye test and you have sensory processing disorder. Okay, you're in an unfamiliar place with new people, and you can smell the remnants of someone's lunch. There's a strange whirring coming from one of the machines in the room, and the optom turns off the light suddenly and it startles you. And then they shine a really bright light into your eye. And at the same time, they're so close, you can smell their perfume and it's mixed with the smell of what they had for lunch. They're resting their hand on your forehead to steady themselves, and they're asking you to look around the room. And whilst they're doing this, they're chatting to your companion about the cost of parking in the local area. You've had enough, too much sensory input, and the fight or flight responses kick in. So now consider this. You're told that for the next test, the lights will be dimmed and are given time to adjust to this. The optometrist fully explains and shows you the light she needs you to, and explains what she needs to do and what's expected of you. She's chosen a test that doesn't require her to be too close and is careful not to need to touch you. She gives you plenty of breaks and check-ins at various points to ensure you're okay, and she doesn't speak to the other people in the room and instead ensures all her attention is on you and she can be aware as soon as things become a bit too hard. Nothing's actually changed with that test. Nothing was taken away, and actually not really many reasonable adjustments were made, but you're just managing the situation a bit better. So I would say that coming back for a different day for this part of the test might be a reasonable adjustment. Anyway, assessment of ocular health. College guidelines state that the bare minimum is assessment with a direct ophthalmoscope on an undilated eye. If you can get them sat on a slit lamp for bulk and then tolerating it, happy days. But for some patients, this isn't an option, especially if you've got a patient in a wheelchair, or particularly the electric wheelchairs or the power-assisted wheelchairs. They're very big and bulky. Most practices that I've worked in have always had a combi unit, and the chair's not able to be moved, so you're not going to be able to access the slit lamp very easily. So you've got your direct ophthalmoscope. It's a domiciliary optometrist's tool of choice, but you have got other options. There's the binocular direct headsets that you can use, but I don't think many private practices have those hanging around. You might have a portable slit lamp, and if you've got a very steady hand, you might be able to manage bulk on that if they allow you to. And with the external eye, you can get yourself a portable slit lamp. There are much cheaper, smaller portable slit lamps. Personally, a high plus lens and a pen torch, or even the indirect lens, is quite useful at magnifying enough to get a good view. So, to prescribe or not prescribe, that is the question. And I have a few questions that I would run through in my head when deciding this. And if you just remember that sentence about what we're required to do by law here, so that sentence was to ensure that people with additional needs can access the services in the same way as other people. So I often just get my head around that and think, what would I do if this person didn't have a disability? So that's my first question. What would the impact be on the prescription of on the person's life? Is it going to make a big difference to their vision? What's their visual function like, and what's their visual habits? Do we think they're CVI and it's quite profound? And would the prescription make much of a difference? Are there any constraints that may make glasses wear difficult? For example, somebody who's autistic that can't stand to have their face touched might struggle to wear glasses. Are you wanting those glasses worn all the time, or just for specific tasks? And are they going to be able to put those glasses on themselves, or are they going to need help to do that? Will the glasses be tolerated? I put that one with stars by it, because you often get the unhelpful helpers insistent that the glasses won't be tolerated. The way I see it is, if they're a -10, the glasses might not be tolerated, but if they don't have the glasses in the drawer, they're not going to have the opportunity to even try it or see the vision the way it could be. You can't insist somebody buys glasses, but you can certainly recommend it and advise that it may be better. So, providing them with their outcome. So, College guideline says that we must provide information in a way that the patients will understand. And there's actually there's a bit of legislation that's related to NHS patients, but it actually covers it actually covers eye specialist optometrists and DOs and as well. It's about the accessible information standard, and it applies to anyone with a general ophthalmic services contract, basically. And that's ensuring that, that the information is presented in a way that that patient can understand. So whether that's large print, or whether you're using a different form, or a picture story. So there's a social story down there, the getting eyeglasses one. There's a lot out there on the internet actually that is free resources. So your basic prescription, here's my catchphrase, seeability, I've got the form for that, okay? The eye test results form, again, it's a free downloadable resource that it goes into a little bit more detail and explains the results of the eye test in plain language, and it breaks it down for them. It's also really useful for this to be put into a care plan or shared with people that they may be being looked after by, so that they can have a better understanding. It gives you a chance to explain the results of your test and how well somebody is seeing, or how they see, to those around them. They actually did have a different form a little while ago. I can't find this form. I think it's an old form, but I actually prefer it to the current form because this one's got pictures on it. So I think it's even more accessible. They've taken a lot of this away from their new form. I've kind of put it on here in an effort to demonstrate. You could make your own one. You could make your own of any of these. But there is a lot of free resources out there, and it's just about making sure it's accessible. So send in the dispensing opticians, okay? Ideally being seen by a qualified DO or very experienced dispenser. If there's any vision impairment, obviously they need to be seen by qualified member staff anyway. So you can get comfortable glasses. The sprung hinges are possibly not the best option for a patient that can only use one hand, because they're going to end up, any glasses are going to end up splaying. Even the flexible hinges, they can become under stress and they can break easier. So you might find that something that's really flexible and bendable might be better. There's obviously various different adaptations to lenses. I'm not going to go through this in too much detail, but you can have straps. Also bear in mind, somebody with a hearing loss needs both the hearing aid and the glasses to fit well. You can get glasses with hearing aids attached to them, but from what I understand, neither the hearing aid or the glasses part does their job particularly well, and a patient's usually better off having separate implements to do their different jobs. So, hospital eye service involvement. So we're sending a patient into the hospital. There's a really busy waiting area, and the clinic's running quite behind. There's lots of children crying, lots of talking, there's lots of noise. Add to that the fact that the hospital is huge, and you've got to find waiting area B on level 2, going through the main entrance. I get lost, and I'm there 3 times a week at least. And that can all become quite overwhelming. Do the hospital need to be involved? So I'd say, again, think about that sentence. What would you do if somebody didn't have this disability? If they've got new pathology that needs looking at, yes, absolutely, we want to see them. But if it's just because you can't do the test or view the fundus, or difficulty in finding a refraction, I'd just query whether a referral to us is needed, okay? We don't actually have a commissioned pathway to do adult refractions. We do see some patients for refraction within the hospital eye service, but we kind of have to fit them in here and there, and it's not actually a commissioned pathway. But hey, Sarah, stop. You're going to say to me, that you've got a responsibility to refer on when something is out of your scope of practice. So what are the alternative options? You don't necessarily have to refer into the hospital eye service. You could refer to a colleague down the road who's got different equipment that can meet the need of that person. You could recommend a domiciliary service. There's a fair few about now, and a lot of patients are able to access that eye care in their home. When I did domiciliary eye care, I used to push patients to do it because actually the bigger companies, certainly the equipment, the eye test that they're getting is pretty much on par with the eye test that they can get on the high street. As I was leaving the outside clinic, all the optoms were getting fundus cameras, and last I heard they were trialing portable OCT machines. So they get a very good service at home, and that may well be much more comfortable for them because they're in their own surroundings. They've got a lot of extra time and it's quieter. They can have other people there if they need it. There are various other options. If you need to send them into us, we'll always see them. We'll always look at the referrals and judge each person. We're not going to reject them unless it really isn't needed. I just would ask that you think about it because we're quite overloaded at the best of times. So case scenarios. I just thought we'd go through this, and I don't know whether I can see the chat at the same time. So I might need Ian to kind of kick these ones to me. But I'll read them through for you. So Caleb is 30 years old. He attends your practice for an eye test. As the GP suggested, he has one at his annual health check. Anybody with a learning disability in any adult with a learning disability in the UK should be given an annual health check every year, as they are more likely to not report problems. So that's a plan in place. So Caleb has cerebral palsy. He suffers from epilepsy and has a profound learning disability. He's non-speaking and has limited communication, and he can't follow instructions. He uses a powered wheelchair to mobilize that's controlled by his carers. He doesn't wear glasses, and as far as anyone knows, he's never had his eyes looked at. The carers advise you that Caleb watches the iPad and likes to look at the pictures on phones. Caleb has attended today's test with a relative who also has power of attorney. So I just want you to think, maybe put into the chat some ideas of reasonable adjustments that would be good for Caleb. And Ian, I'll need you to go through those. I don't think we can see it at the same time. Anyone got any ideas? Can you see it at the same time? Has everyone gone to sleep?
Nobody typed in the box yet. Maybe you could go through what ideas you have for us to give us a...
Yeah, I'll go make them easy. Okay, so Caleb, his wheelchair is going to take up quite a bit of room in the practice. He's going to be sitting closer to the testing chart, so that you need to consider as well. In this case, Caleb's probably not going to be able to manage a vision test, but it's worth checking anyway with one of the methods. Possibly ensuring that there's a ramp so that they can get into the opticians. We could provide the All About My Eyes form and his health, so that if he's unable to tell us things and he's with carers, they might not know the full details, and we don't know who the relative is, whether it's a close relative. Yeah. Pre-meet the team, yeah, that's a good one. So getting some information ahead of time would be good. Understanding what things might that Caleb likes or doesn't like in terms of whether he is sensitive about people touching his face or getting too close. Might help you choose the appropriate tests, possibly using sort of a direct and indirect headset to view the fundus. And if he's never worn glasses before, and nobody has any knowledge of him ever having his eyes looked at, then I would say in this case, a cycloplegic refraction is a good idea too. Yeah, that's a good idea. Asking how Caleb shows positive responses. Yeah, he may make a noise or make sounds. So that's quite handy to find that out. So let's just move on to the, why is this not working? There we go. So here are our clinical findings. So with vision, you've got the Keeler cards were attempted, but there's no clear interest shown. But he fixes and follows lights and larger items in the distance, and he reaches for beads on his tray. Actually, that reminds me, I didn't talk about the Bradford Vision box that Seeability have been involved with. It's a box of various visual stimulus that you can use to gain an understanding of visual function. So that's what we're talking about here with following lights and larger items. And then there's some beads for them to try and reach to. I always remember hundreds and thousands being one that see they're picking up hundreds and thousands. So there's quite a prescription there. We didn't like having trial frame put on, so we held the lenses during retinoscopy. Fundus and media was fine, but we didn't get a very good fundal reflex view because he became quite agitated and didn't want to continue. The eye care tonometer was used, and that's quite a non-invasive tonometer, and I think a lot of practices have got that now, and that was all normal. So just thinking about whether we're going to give glasses or not, the carers felt that glasses are unlikely to be worn, and they don't notice any issues with Caleb's vision. Besides, he only looks at his iPad and occasionally the TV. So are you going to give glasses? And do you think that Caleb is likely to have any CVI? So Claire said yes, she's going to prescribe glasses. I think that's a fair one. I think you'll, as I said before, you're going to recommend it. They don't necessarily have to follow through. With the CVI, he is possibly likely to. It's much more common in patients with cerebral palsy, so that needs to be sort of on your radar as well. If you're referring in for CVI, I guess you'd need to decide if you think it's significant enough. If the vision isn't adding up with, so if you were to give glasses and Caleb's vision isn't coming up, or he's not responding to it, then you might want to think CVI and referring to have that looked into. I'm just having a quick read. Yeah, ask the carer to build up wearing specs with positive interaction and a little time. Yeah, it is a significant prescription. Yeah, give the glasses for distance and see if they wear them. Yeah. The other thing is, are you giving the full prescription or maybe a tailored, a sort of a partial prescription? I think I might go full to begin with. So I've written a what if. So what if you suggest glasses? Caleb's power of attorney agrees with you, even though the carer feels it's a waste of money. The DO supplies a basic pair of distance glasses, and you repeat the fundus and media check at the glasses check collection. and manage a pretty good view with patience and perseverance. You arrange to review the patient with a DO in 12 weeks' time, which is quite a good check-in if you've not, if it's first-time glasses, to see how they're getting on. At the 12-week check, it's actually conducted over the phone because Caleb's not well and isn't able to attend. The relative tells you that initially Caleb didn't wear the glasses or want to keep the glasses on, but after a little time, he would allow periods of wear. They've noticed that Caleb has appeared slightly more visually alert, especially when the TV is on. He seems to fix on the picture more now compared to previously, when he was possibly only responding to the music. She's so grateful for your lengths that you went to in order to accommodate Caleb's need, that she's booked herself and her husband in for an eye test next week. So I know that there's a lot of commercial constraints in the high street, especially when you're giving multiple visits to one patient. You might have managers a little bit upset about conversion rates and things. The way I see it is, if you look after them really well, then you're going to get families that become loyal customers to you. So it's still, there's no real, there's no excuse for not seeing the patient, basically. Okay, I think that was all for Caleb. So case scenario 2 is Jessica. Jessica is 19 years old and she attends your practice for an eye test and feels she's struggling to see text clearly on her phone. She's worn glasses most of her life and last had an eye test about 7 years ago as has struggled to find an optician she feels comfortable with. She was born with Down syndrome. She has a mild autism and a mild learning difficulty. She lives within an assisted living residential home for adults with learning disabilities, but has her own small flat with a kitchenette and manages to live as independently as she can with some support from the staff. Jessica has a part-time job working in a hairdresser, doing the hair washes and other tasks. And she's brought her PA with her from the residential care centre. Her PA is there to support Jessica to understand and to help her make decisions, but the PA does not have power of attorney. So, any ideas for reasonable adjustments for Jessica? Does she need any reasonable adjustments? Is there anything you might consider doing prior to her visit? I would probably still get a history and symptoms form filled in so that you've got that information, because that time can be spent. Well, yeah, care plans are brilliant because care plans are going to give you a lot of information about health, any medication. Yeah, that's brilliant. So asking all of those things is really important. Seeability form, yeah. I mean, the seeability forms, I'm gonna send out a list of resources, really helpful resources to you, and the seeability forms are really helpful. Okay, so the clinical findings are fairly good vision. She's struggling a little bit with her reading. And she was quite slow to read the chart. And she did manage a subjective refraction, and you didn't do a cyclo because you had her old glasses. The fundus media was healthy. There was some mild blepharitis, nothing really to note. She managed to sit at the slit lamp, but she needed a little rest between the eyes as the light was too bright. Her IOP is perfectly normal. And she's really happy about that because her biggest fear was that she was going to have a puff of air, and you used an eye care. So there is a slight difference in her prescription from her old one. You can offer her a little bit more plus. She was slow to read the near vision chart, so you're concerned that maybe a reading ad might be needed. As you know, people with Down syndrome often need reading additions earlier than people without. And Jessica's inquiring about contact lenses for occasional wear and when she's at work. And her PA voices that she doesn't think it's a good idea. but Jessica still seems keen to explore the option. So my question there is, how can we manage the contact lens side of things? Are we thinking this might be a good idea, or are we thinking this is a bad idea and to just shut it down and stop talking about it? Great idea, try. Yeah. So again, thinking about that one sentence I want you to take away, we're wanting to access the services in the same way as anyone else. So we need to give her those opportunities you can discuss the concerns of the PA. You could ask a bit more question. Yeah, give us more information about the lens fitting. Yeah. So I think exploring the concerns that the PA has is quite a good idea, because it may just be that she tells you, well, actually Jessica's not very she doesn't clean her hands very well, she might give you some information that might be a contraindication, or it might be that she just doesn't think it's a good idea because she's got no real reasons, or she doesn't really understand. Keeping contact lens in view, say 1 year after adapted spectacles. She's already wearing spectacles, so I don't think that's necessarily needed. I think where Sarah said let her see and feel contact lenses. So the what if that I kind of had for this one is, what if you give her the choice to try contact lenses? She attends for a fitting, but starts to panic when you try to insert the soft lens. You suggest she goes for a little fresh air, then returns to have another go. When she comes back, she lets you try again, but again she struggles and she becomes upset that she can't do it. Her PA suggests that they leave, and she can see Jessica's getting quite worked up. A few days later, Jessica returns with her PA, and they thank you for letting her try and not completely dismissing her. But when they considered all the factor of wearing contact lenses, costs, insertion removal, they've decided to stick with the glasses for now. And she leaves happy because at least she got the chance to try it. Okay, so this is the last case scenario that I'm going to go through. And so bear with a second. Can you turn the light on because I'm sitting in the dark? Sorry. Hopefully, yeah, there you go. I didn't want to leave you all going to turn the light on. So scenario 3, this is Jamie. He is 48 years old and he attends the practice for a routine eye test. Jamie has an acquired cognitive impairment following a head injury 16 years ago, and he uses a wheelchair to mobilise and is struggling to communicate due to his aphasia. So aphasia is like the patient I told you about. They struggle to get the information out. They struggle to communicate. He attends the sight test with his wife, who's also his carer and next of kin. Jamie's wife advises you that Jamie has a lazy eye as a child and a squint, and had glasses for driving before the injury. Jamie has tried to respond a few times to your questions, but each time his wife has answered for him and he appears happy to let her. Jamie gets tired easily and often appears half asleep. So can you think of any reasonable adjustments for Jamie? Obviously, he's in a wheelchair, so again, we need to consider this. Time of the appointment, yeah. I think just allowing yourself extra time, not to rush as well, is really important. We'll put a pin in the safeguarding one. We'll come back to that in the question answers. Maybe Ian, you can write that one down because I will forget. Splitting tests over multiple visits. Yeah, he does get quite tired. Okay, which is good. So I wanted to ask, as his wife is answering most of the questions, hopefully you know that you're directing the questions to Jamie. I'm going to show you what. So Jamie, I don't know whether I'm hoping that my changes saved. So his clinical findings are: he's being tested at a slightly shorter testing distance due to the wheelchair, but he's using a matching card and is nodding for the near vision test and is managing fairly okay vision. We know that he has a lazy eye already. He's got a little bit of a refraction there, more so in the right eye, which kind of again fits in the fact that the wife has told you that he had a lazy eye as a child. The subjective is difficult as you can only get yes and no answers, so you are fairly reliant on your rep results, and the patient's becoming tired. There's nothing to note really in the health of his eye. Slightly tilted disc. There's a pupil defect present, and a small RAPD. IOP is fine. And Jamie wants to get new TV glasses as he gets the odd headache or eye strain when watching TV. You explain that you've noticed a defect in the right pupil. His wife isn't aware of any pupil issues in the past and hasn't noticed anything, but she says he's had a brain injury. It's likely to be related to that. So, are you referring him? So, is there anything? Yes. Because we're not going to assume. So the what if for this one is you decide to refer him because you want to check the pupil defect out. He has an MRI scan done, and it identifies an aneurysm on the internal communicating artery in the cavernous sinus that's compressing and giving a third nerve palsy, which could be masked by the fact that he's a little bit sleepy, so you might not necessarily see the ptosis. He's already got a lazy eye, and he may already have, well, his eye's probably going to be down and out, but you may look at that and think, oh, well, I know he's already got a squint. So, never assume, as it may be something else, absolutely. And in this case, you refer to neurology to have treatment, and his wife comes in to tell you about it, and she's so glad you investigated further, as she has a tendency to assume everything is related to Jamie's injury 16 years ago. Okay, that's the last scenario, and I've just got one more little video to show you. There's one swear word in it. I will give it a 15 rating, but you're all above that. So here we go.
Hey bartender, you assumed that I cannot drink a margarita, so you don't serve me a margarita? If I don't drink a margarita, your assumption becomes reality. And parents, you assume that I cannot live on my own, so you don't encourage me to live on my own, so I don't live on my own. Coach, you assume that I cannot hit harder, so you don't train me to hit harder, so I don't hit harder. And teacher, you assume that I cannot learn Shakespeare, so you don't teach me Shakespeare.
Old MacDonald had a farm,
so I don't learn Shakespeare. E-I-E-I-O. But hey, if all your assumptions become reality, then assume that I can drink a margarita. You serve me a margarita, so I drink a margarita. Assume that I can live on my own. So I live on my own. Assume that I can hit harder. So I hit harder. Assume that I can learn Shakespeare. So, what fools these mortals be? I learn fucking Shakespeare. You assume I can swear, right? Assume that I can do that job. That I can go to parties. That I can have sex. That I can be on stage. Assume that I can. So maybe I will.
So, there's quick references. Oh, if you wanted to hear a bit more, this is my cheeky plug. At work, we are doing a paediatric in-person CPD event. So if you'd like to come, there will be food. It's in September. It's in the evening at Eastbourne District General Hospital. Please do scan the QR code. So spaces are limited. There are spaces at the moment. So if you fancy coming along, I'm only hosting that one. We've got some fantastic speakers. So you'll hear a bit from me, but not as much as tonight. And I'll put that back up in a moment, but that's it. Are there any questions?
Thank you very much, Sarah. Do you want to put that QR code back up just so people can
Yeah.
do it? There are a couple of questions. I'll read
There you go.
Thank you very much. That was really interesting. I particularly like the case scenarios. It makes you think about how you are with adults or patients with additional needs. So they're really interesting. Thank you very much.
Yeah.
So if you're ready for the questions.
Yeah, there was the one in the chat that I have remembered to come back to about the safeguarding. Should I start with that one?
Yeah, you want to start with that one?
I don't profess to be the best at this one. I might not be able to answer it, but I think safeguarding is difficult. You can ask for a colleague to maybe sit in and chaperone. I guess it depends on the patient. If they're a vulnerable adult, you need to have that in consideration. But there's no real need to have somebody there if they don't feel they need one. They might be able to give you that indication, but if you feel that you'd be happier with a chaperone, then you can ask a colleague to attend as well. I guess your own companies will look at different safeguarding policies, so maybe it's important to sort of be up on that, because as a vulnerable adult, they'll be at risk of, or they're what's the word? Not at risk. They're vulnerable to neglect and things, so it's important to be on the lookout for that. But in terms of safeguarding in your room, I think it depends on the person you've got.
Thank you very much. So first question in the questions box. How would you politely ask a carer or guardian not to help the patient? It happens all the time, doesn't it? You see, children, you show a picture of a duck or something, the parents in the background making quack quack noises.
Yes. Oh yeah, don't. Well, I actually witnessed a member of staff doing it the other week. Yeah, I guess I think obviously being polite in your manner, but explaining why not to help. So maybe allowing a little bit of help to gain a bit of confidence isn't a bad thing. But ultimately, I think most parents, if you say, well, actually, you're giving them the answer, I need to know that they've seen it, or they're without a guess that you're helping, most of them will take that sort of as a polite back down. But if they're not listening, then you can be a bit more stern and say, actually, I'm going to need you to be quiet whilst I do this test, because I need to do this test properly. So start with polite and make it fun, and ask them to stop, and then get assertive.
So do you find patients tolerate cyclorefraction okay in terms of sensory overload, etc.?
Yeah, I suppose that's quite a good question. Most of the time, certainly the patients we're seeing in the hospital, just the setting alone is already causing enough of stress. So it's sometimes hard to know whether it's the cyclo causing overload or not. But I think again, it's communication. Maybe considering having them pre-dilated and coming to the appointment dilated. So doing everything in the test beforehand that doesn't need a dilation, and then sending them away and getting them to come back may well be appropriate there. Using Seeability actually have in their eye test picture chart, it does talk about needing drops. They've also got another one about the process for diabetic screening, which goes into drops as well. So I think if they're pre-warned, if they don't necessarily have the ability to understand, I think you need to do it to be able to get the responses. You need to do it to be able to get the test, so you're going to need to do it. But generally they're okay, especially if they know that they might be a bit blurry. With the sensory problems, sometimes the example I gave earlier about the two, so having sort of the bright lights, the person not listening to you, that we didn't change anything with what we were actually doing. We just kind of counsel the patient a bit better through. And I think sometimes if you can maybe cut down other sensory overload problems, like giving them a quiet space to sit whilst they're waiting to dilate rather than in the main waiting area. I know it's not the same, but it's my experience with Ethan. If he's overloaded and dysregulated, it might not be noise that's the problem, but simply taking that sense away or muting that sense brings everything down to cope better, because it's just helping to manage the situation. So honestly, the carers and next of kins are the experts too, so they can usually help say what's going to be the answer for that patient too, and help.
Brilliant. Thank you very much. You're off the hook. There's only those questions. So, but you did a fantastic talk. It's really enjoyable. So thank you very much, Sarah, for your time.
No problem. I will, I'm going to do a resources list, which I'll give to Ian and he can send out when he does all the certificates for you.
Extra work for me. Thank you very much.
The
certificates are probably, well, say I have 10 working days to get them out. I'll probably get them out early part of next week. So, and if you keep watching on the group, I'll let you know about the next webinar that is sort of provisionally being planned, but watch out for updates on that. So thank you very much for watching, and thank you very much again, Sarah, for that wonderful talk.
Thank you for coming.
Bye all.
Bye-bye.
Bye.